I am Dr. Kathryn Fife. I go by Katie, which is why everyone's calling me Katie. A little bit about me. I graduated from the University of Michigan Tech back in the day for my undergrad, and then I graduated with my doctorate from the University of Minnesota Twin Cities. So I have a little bit of a Minnesotan accent. So if you don't understand me, please message in and I will repeat in a more Arizona-ish accent. So to get started, how do I pull up I'm pulling up the PowerPoint and someone's doing it for me. Okay.
One moment, everyone. Sorry, little technical difficulty.
Oh, do you have to click like,
oh, slideshow? Okay.
All right. Okay, well, thank you everyone for coming to the Incontinence Workshop. I'm super excited that so many people decided to show up on a Saturday morning. To get started, I already talked about my background. I am a current women's health resident. That just means I'm going through more training to sit for my specialty board. So I still have a full caseload and I'm still seeing patients, but I'm just doing a lot of didactic extra work right now to get into more of a specialty. But I treat as a pelvic health therapist and I've taken a few continuing ed, as you can see. I wanted to go over a little bit about what pelvic floor physical therapy is, just because I think that it's relatively unknown, and I think we have a large ability to help a lot of people that don't know about us. So I'm starting off with this, but I will get to the incontinence workshop, I promise. So what is pelvic floor PT? It is a special form of physical therapy where we specialize in treating the pelvic floor muscles, and we also specialize in treating specific women's health conditions. So this is a list of things that I treat, and there's 4 slides. So I treat a lot of stuff, and starting off with stress urinary incontinence and urge urinary incontinence, functional urinary incontinence, which we will cover during our incontinence workshop. I also treat interstitial cystitis, which is also called painful bladder syndrome. I treat fecal incontinence, constipation, irritable bowel syndrome, and I treat a lot of pregnant mamas. I see them in the beginning of their pregnancy, towards the end of their pregnancy, and the majority of them in that second trimester, because that's when they're feeling really not so great. And then I see them postpartum for prolapse, urinary incontinence, pain with sex, and diastases.
Sorry, we're just going to admit anyone who may have not been let in yet. Give us one moment. Okay, perfect.
Okay, now to the next slide. So we also do prehab and rehab. So a lot of these procedures, we will do physical therapy before to kind of enhance the surgical outcomes. And then I'll also see a lot of these patients post-op to kind of, again, enhance those surgical outcomes so that you get the most out of your surgery. So your bladder slings, bladder suspension, bladder reconstruction. I see people post bladder cancer, sacral corpulplexy, pelvic floor reconstruction, C-section is a big one, hysterectomy, ovarian and uterine cancer, and then rectal cancer, colostomy, bowel reconstruction, breast cancer, mastectomy, breast reconstruction, prostate cancer, and another huge one is post-prostatectomy. Oh, did I click something wrong? Oh, I'm sorry, guys. I'm so technologically challenged, but I promise I'll get the hang of this. So functions of the pelvic floor. This is where I get a little excited and nerdy, is that what other muscle group can you name that has 5 like unique functions to it? The pelvic floor is supportive. It's the bowl at the bottom of your pelvis that supports all of your organs and musculature above. It also has sphincteric control. That's kind of where we talk about those more external muscles that close the urethra and close the anus and prevent leakage. They also support stability wise, your deep pelvic floor muscles or your levator ani support your bladder neck, which also helps with continence. You also stabilize your back, your core, and your hip muscles. So people that have hip pain, back pain, any like pelvic pain, I always check pelvic floor to make sure that they're properly stabilizing and using those muscles. Otherwise, you're overusing your back, you're overusing your hips or your tummy muscles, and that's what kind of causes that pain and dysfunction. Our pelvic floor muscles also have a huge role in sexual function. Our external pelvic floor muscles attach to our clitoris, and they're actually that huge contraction that you get with orgasm is your pelvic floor muscles. They also allow for pain-free sex if the muscles are loose and functioning properly. When I see dysfunctional sex, like people that are having pain with intercourse, either deep or initial penetration, we see like that the pelvic floor muscles aren't responding the way they should. They're not lubricating properly, or they're too tight or spasming. And then the last one is sump pump. So this is the one that's most relatively unknown, is that we have so many lymph nodes in our pelvis, and our pelvic floor actually functions to contract and compress those lymph nodes to empty them into our lymphatic system to get rid of that swelling. When our pelvic floor isn't functioning well, I will see women that have swelling in their bellies and in their legs because they're not properly using that sump pump action to get the swelling out. So, like, if you notice that you have a lot of swelling in your legs or in your pelvis, abdominal muscles, and you're having incontinence, they're often related to pelvic floor dysfunction. Okay, now we're going to get more to that incontinence. So, incontinence is defined as involuntary loss of urine. So, pretty much peeing when you don't want to pee. There are several different types, but the three most common are stress urinary incontinence, and that's kind of the involuntary loss of urine with laughing, coughing, sneezing, and a big one is jumping. My goal with my moms a lot after pregnancy, we see stress urinary incontinence, is to get them back jumping so they can play with their kids without leaking. Then we have urge incontinence, which is leaking on the way to the bathroom. These people often have problems with frequency. They're peeing every hour. They're getting up a lot at night. They have a really strong urge and they can't control it, and they're running to the bathroom and leaking on the way to the bathroom. These people often have pain in their bladder. They feel like they're not completely emptying when they go to the bathroom, and they are constantly worried about if there will be a bathroom available when they're going places. Mixed incontinence is a combination of both. So you have that like strong urge, you're running to the bathroom, you're leaking on the way to the bathroom, but also with that laughing, coughing, sneezing, you're having those small instances of leakage. With stress urinary incontinence, it's typically those deep pelvic floor muscles that control the bladder neck that aren't functioning well. Their sphincters are typically in control, and that's why they only leak like a certain like small amount or a little burst when they laugh, cough, or sneeze, and increase that intra-abdominal pressure, because their sphincters at the outside of their pelvic floor stop the urine as soon as they realize what's happening, but that bladder neck control with those deep muscles isn't functioning well, and that's kind of hard to target if you're just doing Kegels and not activating your deep Kegel, which is something that you probably haven't heard before.
Sorry, we're just gonna make sure we're checking everyone in once again.
Possible reasons for incontinence. So when I'm talking pelvic floor relations to incontinence, I'm just saying that pelvic floor muscles are too tight. We talk about like a tight or a like firm, weak muscle a lot, and that's very confusing to a lot of patients. And I like to attribute it to like a muscle contraction here. If your pelvic floor is constantly fully contracted, it's really hard to contract any further from this position. So you're constantly straining to contract further. And that's why that muscle is considered weak. What I do with those patients is we work on lengthening before we strengthen. So then you can get that nice full contraction to keep your continence and prevent leakage. With pelvic floor muscles being too weak, it's kind of what you would think. They're not able to squeeze hard enough to close those sphincters or to support the bladder neck. And then pelvic floor dysnergia is a really common one that I see. And that's when people think they're contracting their pelvic floor, but they're actually pushing down and out. So a pelvic floor contraction is pulling up and in. And a lot of people after baby with any neurological conditions or aging and atrophy will do the opposite. They think they're pulling up and in, but they're actually pushing down and out. So then if you're pushing down and out to prevent leakage, of course you're going to leak. And that's why it's important for people that have tried Kegels and they're not getting anywhere. They feel like it's not helping with their incontinence or it's not helping as much as they think it should. That's why it's important to come and see a pelvic floor therapist, because nobody thinks that they do this that do. I swear, everyone's like, no, I'm pulling up and in, and they are pushing down and out. And it takes like a lot of like neuromuscular control training to regain that like proper contraction. And it's very common, a lot more common than you guys would think. And nobody thinks they do it. I actually had pelvic floor dysnergia and I was so convinced that I was pulling up and in, and I definitely was not, but like I needed somebody to tell me that, because you feel the sensation like you're actually doing it properly. And that's why so many women don't perform Kegels correctly, even if they get instruction from doctor, even if they get instruction from online, is because the sensation makes you feel like you're pulling up and in, but you're actually not. So just a little food for thought there. So some contributing factors. We kind of talked about that poor Kegel form. Another thing that people do wrong with Kegels is they contract every single muscle in their body. So they activate their abs really hard to stop urine leakage. They activate those muscles on the inside of your thighs, your adductors really tight to prevent leakage. So you see people squeezing their legs together. That's not like a super effective method. It kind of works, but it's not really activating your pelvic floor. And then glutes is probably the most common that I see people squeeze their butt. A lot of people hold their breath, which is not good. Breathing is a really important part of like our pelvic floor function. And we'll kind of talk a little bit more about that in future slides. And I'll explain like why breath work is really important in our treatments. And then they're doing the wrong exercise prescription is another common one. So you want your pelvic floor muscles in order to have continence to have good endurance, to have good coordination, and to have good strength. Now, women typically have like either all three are off, or they have a couple that are off, or they have just one that are off, and that's what's contributing to their incontinence. So I'll see women that have great endurance, great strength, but their coordination's off. They can't multitask and have that neuromuscular control when they're lifting their legs or squatting down or getting from a sit to stand. And that's another thing that we work on here that's a little bit different than what you would do online. I'm applying a lot of shameless plugs to come into physical therapy, but I really think that we can help people, and people that have already tried Kegels and just aren't getting the results that they want. Another thing is poor deep core stabilization. So I talked about the breath work. Your diaphragm is very interrelated to your pelvic floor. You have these deep muscles in your back, and you also have your transverse abdominis, which is kind of your like girdle muscle that holds everything in. And they're all really related to your pelvic floor. They also, if they're dysfunctional, typically people have pain because they're not as stable as they would like, and they have to contract other muscles really tight to prevent instability. So you'll see people with like back spasm, and it's because that back muscle is contracting really tight to stabilize for poor pelvic floor or poor diaphragm or poor transverse abdominis muscles. And so a lot of my people that I see with incontinence, they have back pain, they have hip pain, they have something else going on, and that's something that we definitely treat. I take a very holistic approach as well as my colleagues do. Okay, here's the deep core. So when I talk about pelvic floor being a core stabilizer, you can see that this like pink at the bottom, the little U-shaped, attaches into your core musculature. So a lot of my ladies that have diastasis after baby, we hit the pelvic floor muscles really hard because your pelvic floor is actually what attaches up into that low abdominal muscle that binds everything together. Also, if your core is really dysfunctional and you're not activating your tummy muscles well, you'll see that your pelvic floor doesn't function as well. So you can see how they're all attached: diaphragm, abdominal muscles, and pelvic floor, and they all attach into your spine. So if you have dysfunctional spine, we'll see issues there. When I do my evaluations, I like to describe the core, your girdle, as a Coke can. You have your diaphragm on the top, your pelvic floor on the bottom, abdominal muscles in the front, hip muscles on the sides, and then back muscles. When you contract your diaphragm, your pelvic floor automatically relaxes and vice versa. You get this kind of synergy that goes between the two. So when I have people with urge incontinence that have a really tight pelvic floor that's struggling to relax, we do a lot of breath work to help them relax that instead of doing a bunch of internal work to force relaxation. So that's food for thought. Belly breathing is something that as women we're often told not to do because we were all told to keep bellies in, nice and tight, like always hold our bellies in. And that's really dysfunctional for our pelvic floor. And I think that's why we see a lot of women with pelvic floor dysfunction as compared to men. Men do have pelvic floor dysfunction at quite a high rate as well. But I think as women, we're just always told to keep nice and tight, keep that belly in, and that doesn't help. So a lot of my training is actually getting women to belly breathe throughout the day to kind of help relax that pelvic floor and get those nice, like, synergistic contractions throughout the day. Posture. Posture is really important. If you think of your pelvic floor as a bowl at the bottom of your pelvis, I don't know if you guys can see this super well, but that's your pelvic floor, all this red. When you're standing with good posture, your bowl is nice and level. When your pelvis is tipped forward, your bowl tips like this, and vice versa. So you can see that it's not going to function as well if you constantly have poor posture. You're constantly putting it at a disadvantage if it has to contract like this to prevent, or like this to prevent, or if you're different side to side and your pelvic floor is like this, it's even harder to contract and keep that continence. So we do a lot of postural training, and honestly, that stuff carries over to decrease incidence of back pain later in life if you don't already have back pain. So that's also an important part of our treatment.
Sorry, again, we're just letting some folks in. All right.
Okay. Other contributing factors to incontinence. So I'm going to talk a little bit about lifestyle habits. Bladder irritants are something that are a little touchy with most of my patients, and I understand why. And I have a whole slide dedicated to that. So we'll talk about that in a bit. Another thing that we do as women very commonly is preemptively empty our bladder. So that's the peeing just in case. So if you're headed to the mall and you don't want to use the bathrooms there, even if you don't have to go, you pee before you go. What this does is it trains your bladder to contract, the detrusor muscle that surrounds your bladder to contract when your bladder isn't completely full. So then you're going to be going to the bathroom more frequently. So if you are a just in case person, I would say try to start limiting that, because you're not allowing your bladder to completely fill before you go to the bathroom, which is just like messing up your like neurological to your bladder control. And that's why a lot of women have to go to the bathroom more often. Hovering, ladies, I know some toilets are so gross, but hovering's not good either. It's kind of that dysfunctional toileting that I talked about. When you're hovering, you're squatting. So your butt muscles are on, your hip muscles are on, your abdominal muscles are tight, and you are pretty much just forcing through your pelvic floor that's already contracted to go to the bathroom. So this isn't good either. So I would say try to limit hovering. I know it needs to happen sometimes. I do it sometimes too, but you don't want to be doing it every single time you go to the bathroom out in public. You want to, like, that's why they have those like paper things that are really noisy in the bathroom because it's not good for your pelvic floor to hover. But I understand with like some toilets, they're just gross. I get it, but try to limit it, please. And then poor toileting techniques. So if you are straining with bowel movements, if you're pushing out, that's really bad for your pelvic floor. So when you're pushing, you're contracting pelvic floor and you're pretty much forcing through a closed sphincter. So I see a lot of women that have incontinence that also have constipation. And that's because you're kind of teaching your pelvic floor to just push through already contracted muscle. So that leads to dysnergia as well. That kind of like you think you're contracting, but you're not. You're pushing down and out instead of pulling up and in. You're telling your system that contraction means push through, and that leads to incontinence for a lot of women as well. I am a huge fan of the squatty potty and just relaxing to let go. If you can't go to the bathroom at that moment and you sat on the toilet for 2 minutes just trying to relax, I would say it's better to get up and walk for 2 minutes and come back and try again than to try to force through. It's just you're training your pelvic floor to do things that you don't want it to do.
Do you want to answer some questions?
Yeah. Are there questions?
Yeah, so we're going to check, make sure everyone's in, and then we're going to see if there's any questions. Barbara?
Houghton, yeah. Yeah, I went to school in Houghton.
Let's see. June got her degree from Minnesota. Can you turn on closed captioning? Unfortunately, I don't believe we have that capability. We will be putting this on YouTube later, and we'll send out a link. That way you guys can always revisit it. Are these
So slow dribbling, I would say is, yes, I will address that right now. So people that kind of dribble throughout the day or have slow dribbling, it's more of that like weak pelvic floor muscle. Like you're contracting really tight to try to prevent leakage, but your pelvic floor just doesn't have that support. And I would say that's typically like a combo. Like you're more in that mixed incontinence and like progressed in that mixed incontinence if you're having that slow dribble. I also see that a lot with people that have poor bladder mobility. So when your bladder, fun fact, is the most mobile organ in your body, or it should be, when your bladder isn't the most mobile organ in your body and it's kind of tacked on from either C-section scars or just that continuously never ever filling your bladder to allow for stretch, we see that when you move and go from sit to stand, that your bladder gets compressed a lot and kind of forces urine out. So we'll see like a lot of dribbling with movements. And then also with just like weak pelvic floor, we just see like constant dribbling. So it's kind of like bracing that up to get that stronger and like a little bit bulkier. Also see it post-menopause. Estrogen is so important for our muscles. Incontinence is not a normal part of aging, but if you had weak pelvic floor muscles and then you go through menopause and now you don't have that extra estrogen to buffer your muscles, then you're going to see a bigger decrease and less likely to be continent. So I see a lot of women that had some pelvic floor dysfunction before menopause that now have significant pelvic floor dysfunction, incontinence, or whatever after menopause, just because that estrogen is really important to buffer the muscles. But we can strengthen those muscles and get you back so that you're not continent anymore, because incontinence is not a normal part of aging. That's one of my soapboxes I could go on for forever.
Margaret asked, preemptive empty. Is it true for men? Should we discourage that for children? I feel like that is really new, or just for women with incontinence? Question mark.
That is a great question. I'm glad you asked that. For everyone, no one should be preemptively at like emptying your bladder. So again, like if you aren't allowing your bladder to completely fill and you're going to the bathroom, you're training your bladder to contract at lesser full levels. So a lot of little girls especially are told like to go to the bathroom before going to the mall or whatever, because you don't want to have to take your kiddo to the bathroom, which I get, but that's actually training really poor pelvic floor function and poor function of your bladder. So that's something that I think should be common knowledge, but it's not. So I would say if people are preemptively, anyone, doesn't matter sex or age, you should not be emptying your bladder unless you have the urge to go and feel like you are going to pee probably for more than 7 seconds. Is if you're peeing anything less than 7 seconds, you are not allowing your bladder to get completely like more full before you go to the bathroom.
Lisa asked, how do you determine if people are actually pushing out rather than up and in, as they believe they are doing?
So that takes time. So people that are pushing out typically are on my tighter realm of pelvic floor muscles. So if you think like I'm really tight, it's really hard for me to pull up and in, but it's easy for me to push out because I have that motion there. So with those people, I typically teach like breath work, and we work on lengthening the pelvic floor muscles before I try to get them contracting. And then my people that are just straight dysnergic that have the length, we work on giving like cues to help them. So like tactile cues, visual cues, like I have women bring a mirror and look down like while they're doing the pelvic floor contraction, and I teach them what to look for, and just getting that kind of brain muscle connection actually really works well. So that's what I do with them. It's different for everybody. Everyone responds to different cues better.
Yes. So Margaret's responded to you talking about holding in, and said, yes, I feel like this is a road trip life changer. I will let the family know. Perfect. Yeah. Pushing to eliminate is bad.
Yes, I will explain that a little bit better. So when you push, like if you're like kind of like, is what I describe it as, you're really contracting abdominal muscles and you're really kind of like pushing, your pelvic floor actually contracts. We talked about pelvic floor having a role in sphincteric function. So when your pelvic floor is contracting, you're actually closing the like opening. So this is common more so for pooping, but it's also common for urinary dysfunction. So you're pushing through a closed sphincter, which is not good. So I give like really weird techniques to help people. Like you're gonna have a little increase in your intra-abdominal pressure, but more like if you were like blowing through a straw. So like if you go, you can kind of feel your tummy muscles tighten. That's about as much as tummy muscles should tighten, and pelvic floor should relax to go to the bathroom appropriately.
And then the last question, any problem with urinating while standing up? Into the continue.
So yeah, that one's tough because if you're measuring your urine output, they typically have people do that. But yeah, there are ways like if you're leaning against something to help you relax pelvic floor more, but it's really difficult to relax the pelvic floor in those situations. Men do a really good job of peeing standing up with pelvic floor relaxed, but for women and others, it's just a little bit more difficult to like relax those muscles. But I do training with some patients where I hook them up to biofeedback, which is like an EKG, but for your pelvic floor. And we work on how you can stand and keep your pelvic floor relaxed at the same time. And it takes like training through that neuromuscular control and coordination, but there are ways to do it. It's difficult, but it can be done. And I do that training with my patients if they need to stand to pee because of needing to pee into a container or something like that.
Alrighty, so that was the last question for now. We'll return back to the questions at the end, and that way Katie can go through some more of the PowerPoint.
Okay, so we will sneak on to the next slide. So lifestyle changes. Everyone should be drinking 6 to 8 glasses of water a day. And why that's important, a lot of women think, I am having urinary leakage. I need to stop drinking so much water. But it's actually, I encourage my women to drink about 6 to 8 glasses of water, because if you're not drinking enough water, your bladder becomes an acidic environment. When your bladder becomes acidic, it contracts more, that muscle, and that's what kind of forces urine out through that like urethra. So you're actually making it more difficult on your body to stay continent if you're not drinking enough water, which seems really counterintuitive, but it's true. You want to create like a nice environment for bladder so you're not contracting as much. And then this is where you get to talk about bladder irritants. So bladder irritants will also make your bladder a little bit more acidic, and you'll get those extra contractions. So caffeine is a big one. Coffee, tea, soda, sparkling water. I'm from Minnesota. I love my sparkling water. It's tough. And then like acidic or spicy foods. So what I tell most of my patients is, in the beginning, we really want to cut them down and we want to slowly add them back in, because I know they're important for quality of life. I know a lot of people need a cup of coffee to poop, all that kind of stuff. So we typically pull away to get to where we want to go. I don't make people completely stop drinking coffee. Like, I couldn't do it, so I'm not going to make my patients do it. But I do want people to be aware that they are irritating. And with my coffee drinkers, I try to get them to like 1 to 2 cups a day. If you are drinking 4 or 6 cups a day, you're really irritating your bladder. Adding things like dairy can be irritating, but like adding like milk to coffee to make it less acidic can help people. And adding like non-dairy like creamers can be helpful. I also tell my people that just can't give up coffee to do a water sandwich. So what a water sandwich is you drink half a glass of water, then you drink your cup of coffee, and then you drink another half a glass of water. What that does is it decreases the acidity and makes your bladder a little bit happier, because I know that stuff's hard to give up.
We have a few questions regarding this one. I saw them pop up.
Oh, okay. Why sparkling water? So that carbonation in the sparkling water that makes it all bubbly is acidic. So yeah, that's why. Some people don't, everyone's bladder is different, and that's why it's kind of hard to make this assumption. Everyone has different triggers that cause their bladder to be more irritated, but these are some of the more common ones. So if you drink sparkling water and don't think it's irritating, I would say try cutting it out and just see what happens to your bladder. And if it doesn't change, then you're probably okay. But I used to drink like 3 or 4 things of sparkling water a day, and when I cut it out, I found myself like my urges to go to the bathroom between every patient went away.
Are nuts a bladder irritant?
They can be. It depends on the person. That's not one of the more common bladder irritants, but it can be a bladder irritant. It's one of those things where I make my patients do bladder diaries, and we look for what is it called? Like if you're doing bladder diaries, you look for like trigger foods. So like if you're always having a bout of leakage after a certain type of meal or a certain drink, we start to pay attention to that. And if we see it like happening a couple times, then we cut it out and we see what happens. It's kind of a like mismatching game to figure out what your body is specifically reacting to and that kind of stuff.
So we'll return to this one after. And then what is an acidic food?
An acidic food. So a common one that people think of right away is like lemons, but lemons actually aren't super acidic and they're okay. So a lot of people that really like tea, I'll tell to have some hot water and a little bit of lemon in. But other like acidic foods could be like grapefruits are pretty acidic. I have like a whole list in the back, and maybe I'll read a few at the end so I can give you guys a few examples and not just go off in my brain, which is decaffeinated right now. Okay, I'm gonna go to the next slide. Great questions, by the way. So lifestyle changes. So bladder retraining is something important that we do in pelvic floor therapy, and that's kind of decreasing the sensitivity of those bladder stretch receptors. And what we do with that is we increase bladder motility, which I do visceral mobilizations. I also do internal bladder modes, internal bladder. Oh my gosh, I'm sorry. Bladder mobilizations if I feel like it's necessary. I always start external though. We also work on water stretching routines for people that's bladders just don't allow enough water because your bladder wants to stretch and be full. It just is really irritated, kind of like the rest of your digestive system. So we kind of work on, I'll do a bunch of bladder mobilizations and then I'll have you drink a full glass of water. You'll try to hold for like 30 seconds to get that stretch, and then you'll go to the bathroom. And then that'll slowly work us towards more and more bladder filling capacity. We'll also work on like educational training to tell bladder to calm down. When you contract your pelvic floor and do a Kegel, it actually tells your bladder to stop contracting. So if you're someone that like is going to the bathroom every hour and you know that you're not like completely full, we'll do weird like little techniques of like certain muscle contractions in certain positions to tell bladder to calm down, and then continue with daily life. And if that urge returns, then you go to the bathroom. It's kind of a give and take thing. That may have been my stomach.
No, it's coming from just as a reminder, I'm going to go ahead and mute everyone. Okay. There we go. Okay, perfect. And then I think you had some questions regarding this one. Is alcohol acidic? Yes.
Yeah, alcohol is a big bladder irritant. So my ladies that like to drink wine, I do too. But yeah, like you have to go to the bathroom, like you get like stronger urges with that. That's because your bladder is in a more acidic environment. It's a bladder irritant.
Could pelvic floor PT help an older man with a very weak bladder?
Yes, I see a lot of men as well as women and transgender people with weak bladders. Everyone can have a weak bladder. I see little kiddos with bladders that aren't functioning properly, and pelvic floor therapy is definitely typically indicated. A doctor will be able to determine like if it's a weak bladder for a different reason. It's kind of a specific question, but that's why we're doing free consults. So you can always come in and find if you're a good fit for physical therapy. I never see a patient that I don't think is appropriate for physical therapy. I'll straight up tell them during the evaluation that I don't think that will accomplish the goals that they want to. I'm very honest. I very rarely have patients that I don't think are appropriate though.
Oh, and sorry for any confusion. This is actually Kathryn Fife. She's a physical therapist. She's using my computer. I'm not a therapist, but she does practice in Tucson.
Yeah.
At our Swan location. Can neuropathy contribute?
Yes, it can. Neuropathy can contribute to pelvic floor dysfunction. A lot of people that have diabetes specifically have pelvic floor dysfunction, and it's becoming more and more common in our research that we're realizing that a lot of people with diabetes have neuropathy of the bladder and have decreased vaginal sensation and all that kind of stuff. And I do see a lot of those patients as well to kind of help them accomplish their goals of improved continence and actually improved vaginal sensation as well.
Okay.
Okay. So this is where I'm going to put my shameless plug in. We are giving out free consultations to people that give their information to my beautiful HR team after this. And what a free consultation will do is we'll sit and we'll chat, and I'll ask you a bunch of questions. I'll ask about all those things related to pelvic floor function. I'll ask about urinary incontinence. I'll ask about frequency. I'll ask how many times you're getting up at night, how many times you're peeing during the day. I'll ask about constipation, fecal leakage. I'll ask about sexual function, pain with intercourse, all that fun stuff. And then I'll ask about if you have any tummy, hip pain, back pain, any problems with your spine, all that good stuff. And kind of, I like to delve into childhood because I feel like a lot of these problems come into childhood, but then we'll talk about what I think I can do to help you, why I think you're a good fit for physical therapy, or if I don't think you're a good fit for physical therapy, and then kind of what an evaluation would look like. During the consultations, I am not allowed to do any physical exams, but I can get a real good picture of if you're a good fit or not for physical therapy. During my evaluations, then if I saw you previous for consult, we've already talked. I might ask you a few more questions, but I'll assess like the balance of your musculature. So are you same side to side in your hip musculature and length and abdominal muscles versus back muscles? Kind of, we talk about that pelvic floor being a bowl. If you're really tight on one side and like a little twisted, then your pelvic floor isn't going to function well. Then I typically do some sort of pelvic floor assessment. I do internal assessments, but I always offer patients 3 options. So the first one's an internal, and I really think that an internal gives me the most information. It tells me if your deep pelvic floor is contracting as well as your superficial pelvic floor. It tells me if you're contracting on both sides. It tells me if you have any pain. So a lot of times when I do an internal assessment in someone that has back pain, I'll find like a trigger point or a spasming muscle that's actually referring to their back for their back pain, and we treat that right then and there. I also can tell if you're doing a proper contraction. So if you're squeezing up and in versus pushing down and out, and I'll even like work with tactile cues from my finger to get people to know what the proper contraction feels like. And then I can assess tone and all that kind of stuff that's more related to like how I'm going to form my treatment plan. I also can do biofeedback. I do EMG. So, like I said, EMG is like an EKG, but for your pelvic floor, we put sensors on people. They're just stickers, they don't like poke into your skin or anything. And then we both look at a computer screen, and I can see your resting tone. I can see how well you contract, how well you isolate, all that kind of stuff. And I have norms for where I want people to be in certain positions. So we kind of talk where you're at, where we want you to go. And I use that for treatment a lot. Then my last way is my least invasive way, which is just like feeling over pants, like kind of in your butt cheek. I can kind of dig in and feel if you're doing a proper Kegel, because I can feel the activation of those muscles in certain spots in your butt. But I do that over clothes. And I have seen success with all my patients with those. It just takes longer and is sometimes a little bit more difficult if I don't have as much information to formulate a very specific plan. But it's the patient's choice, and I am willing to treat anybody, and I want people to be comfortable with me. So sometimes an internal exam won't happen until like the 3rd or 4th visit, because then patients are comfortable with me and they trust me and all that stuff. I also bring in some of my lovely front desk girls to offer support if people feel really uncomfortable but really want the internal exam, but they just want someone to kind of distract them and help. I'd say 100% of my patients always tell me it's nowhere near as bad as I thought it was going to be at the end. And I always ask because I'm curious. I haven't gotten one say like it's way worse. So just putting that out there. And then at the end of my evaluation, I talk about what our treatments will look like and what I think is going on. I think a lot of times as healthcare providers, we forget to tell people like all the stuff we found in language that makes sense to them. So I go through and I spend quite a bit of time actually just like explaining, these are my findings, this is why I think it was happening, and this is why it's contributing to your dysfunction, and this is what my treatment will look like for you. And we kind of talk about how long it'll take and all that fun stuff. Yeah.
There's a few questions.
Okay.
We can get it up. Let's refer back to that one up here real quick. This one. So Kiana said, I injured my back 20 years ago and have suffered from bladder leakage since. I've been taking medication since, but I want to get off of it. Is it difficult to get off this type of preventative medication for physical therapy?
Yeah, so I do see a lot of women that don't like the medication that they're on because it like gives you dry mouth or other like side effects. And I'll work with people and most slowly wean off the medication with contacting doctors. So that's kind of something where like I like to have talk to the doctor on the phone or via email or something just to make sure that that's actually safe for you. So that's where we kind of work together as a team to determine. But I do see a lot of patients that want to come off their medication, and we work on strengthening so that they can come off their medication and still not have incontinence.
I don't have incontinence, but frequent urgency, still a candidate for PT.
Yes. So you are like in the early phase right before like urgent continence sets in. So I see a lot of people that just are like going to the bathroom all the time and they're not leaking. But yeah, common diagnosis that I see is like frequency of micturition, which just means you're going to the bathroom way more often than you should be. And that just means your bladder is irritated and is we need to calm it down and get your pelvic floor to support bladder better. And we need to figure out what's irritating your bladder and kind of retrain you to get used to having a full bladder and all that kind of stuff. But yeah, I do see people with similar stuff to that.
Has this field progressed in the last 10 years? Any new techniques?
Yes, this field has progressed a ton and it will continue to progress. There are lots of new techniques for pelvic pain. We're seeing like dry needling in the pelvic floor region, which sounds scary. It's not that scary, but it's something that a lot of my colleagues do. I am in training for it. So I don't do it, but I do typically refer my patients to my colleagues if I think that that would be beneficial. The visceral mobility that I was talking about is something that's like new and upcoming. It's kind of mobilizing your bladder via like external techniques to get the bladder moving better. That's kind of new and upcoming. And I've seen really good results with that. Um, I'm trying to think like the biofeedback, I don't think is quite new, but we've changed it. So we used to do internal sensors for biofeedback, and now we've discovered that using external sensors gives us just the same rating. So it's a lot more comfortable for our patients.
Do you do dry needling therapy?
I specifically do not do dry needling yet. I'm in training for it, so I will, but I do refer to my colleague Melissa and to my colleagues at other clinics when I think that my patients would benefit from it. So then they'll see them a couple times and then come back to me.
And if you are interested in dry needling therapy, you can always give us a call and get rates for that. What do you think of PTNS?
Is that the like nerve stimulation? I'm sorry, Jack. Here, let me Google that just to make sure I have it right. I do have a doctor that I work pretty close with that does what I think you're talking about. Yeah, percutaneous tibial nerve stimulation. So what I think about that is I think it works really well for some people. I think it's kind of expensive and it's something that I can do in physical therapy as well. It's just a little bit different. But if you don't see results right away with it, I would say that it doesn't work for everybody. And then like maybe looking at pelvic floor therapy might be a good option for you.
Can you do an assessment on a man with a Foley catheter? And how does BPH affect your ability to improve pelvic floor function?
So yes, I do see people with Foley catheters, men and women. Well, yeah, I see people with catheters, men and women both, and BPH. So when the prostate enlarges, it makes it harder to go to the bathroom. A lot of men struggle initiating, or they have that kind of stop, go, stop, go, stop, go. And I work with people with that too. We kind of work on strength and we work on mobilizing the prostate and we work on all that kind of stuff to kind of help. And it also can cause incontinence and cause the pelvic floor to have to work harder. So we work on strengthening the pelvic floor with those guys as well.
This is even more informative than I imagined. I have a muscle issue in my back that I have PT for starting November 2nd. Should I do that first before beginning evaluation with you?
So a lot of my ortho PTs, they work in the clinic with me. They will bring me in to consult on patients that they find might have pelvic floor dysfunction. I would say if you can get switched to a pelvic floor therapist, if you think that you're having problems with incontinence, frequency, urgency, constipation, that kind of thing, I would try to see me because I treat a lot of back pain as well. And I think if it's all related, it's better to see someone that specializes in that.
Stem cell for bladder issues, question mark?
Yeah, so that stuff's kind of new and coming, the stem cell stuff. I would say that that's not my specialty area, so I'm not going to say anything on it because I don't know a ton yet, but I have been reading articles and there's been some really good stuff and there's been some like kind of like inconclusive stuff. Um, but I can tell you that physical therapy will only help the results of your treatment if you're going into something like that.
Holly, yes, the link will be shareable. It will be a public video on YouTube. And he answered your question. What does the rest of the PowerPoint look like? We will get to that. Um, and Sonia, yes, our team will make sure to get in contact with you for a consult. Okay, so let's go ahead and move on.
Okay, so treatment. Everyone is different. So all my patients come in. I like pelvic floor physical therapy because they always have more than one issue. So they have incontinence and back pain, or they have incontinence and pain with sex, or they have constipation and incontinence. So everyone is a little bit different. So I treat specific to those individuals and their individual issues. But strength, endurance, and coordination of pelvic floor. I determine where they're lacking, if they have strength problems, endurance problems, coordination problems, or all three. And we design our treatment to work on the pelvic floor and those issues. I work on decreasing tone and tension in the pelvic floor if I feel like that is part of the issue. We work on improved posture, improved breathing patterns. I teach you how to activate deep core. I give you education on like nutrition stuff, lifestyle changes, bladder irritants, all that kind of fun stuff, about toileting techniques and postures. And then we learn how to together how to use your body's reflexes to suppress void urge. I have a little like box of tools to suppress urge, and different things work for different people. And that's why it's really important to come in, because we'll kind of trial a few and we'll figure out what works for you and kind of progress from there. Yeah, so thank you for listening. I have my email down here if any of you have like very specific questions, but you can always ask now because I'm going to go in and answer a bunch.
PT during the pandemic, question mark.
Okay, so let's talk about that. So I think that Body Central has been doing a very good job of physical therapy during the pandemic. Everyone has to wear masks when they come into clinic, and I see all my patients in individual treatment rooms, and I wear a mask and I dress up like I have like more intense masks for my patients that are immunocompromised. So I do have like access to like an N95 and a shield and all that kind of stuff. And I will use that with my patients that I am worried about. We have been doing really good of getting frequent testing ourselves as physical therapists to make sure that I'm not spreading. If I had like, for whatever reason, I got like a little bit of a sore throat or a cough or something, I would immediately call my supervisor and tell him I'm not coming in. And then I would get a few tests before I come in and treat. We're taking it very seriously. We don't want to spread anything to our patients. We're cleaning every room between every patient. We do deep cleans of the clinic pretty frequently. And I have done a few treatments on Zoom with some patients that just can't come in. I don't know if we're still doing that, and it's dependent on your insurance if it'll cover like telehealth, but we have been doing that with some people. It's just a little bit more difficult, but it does happen, and we try to make whatever we can do to make it work and safe for you guys.
Approximately how many therapy sessions would someone have?
Great question. I meant to cover that. So typically for my incontinence patients, I'll see them anywhere from 8 to like 12 times, and that would be over the span of 8 to 10 weeks. This is dependent on if you're doing the exercises, your starting point, and all that kind of stuff. I pretty much like during my evaluations try to give people a timeline of around like 3 to 4 weeks. You should start noticing improvements and blah, 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 blah. And I try to like time it out. If I have someone with a lot of pain, it typically takes a little bit longer because pain kind of inhibits muscle function. And yeah, it's really dependent, but I kind of stick between that like 8 to 10 week mark.
So, okay.